Hi there, class. Welcome back to week 10. For week 10, we are going to review chapters 18 and chapters 19. A lot of material to cover for chapter 18. It's a big, important chapter. We're going to connect anatomy, diseases, ICD-10 coding for the kidneys and urinary system, the male and female reproductive systems, pregnancies, newborns, and congenital conditions all together. You'll see these diagnoses over and over in both the inpatient and the outpatient setting. As I go through the slides, I'll keep bringing us back to what details matter for the code selection and how this shows up in real documentation. So for our learning outcomes, again, this is our roadmap for the chapter. By the end of the chapter, you should be able to code common kidney and urinary disorders, male genital conditions, and STDs. You'll also be comfortable, or should be comfortable, with coding gynecological visits, routine pregnancy supervision, complicated pregnancies, newborn, and congenital cases. And I want you to listen for the details that link directly back to these learning outcomes, because they're the same details I'll expect you to use on your exams and on the homework. Before we dive into the codes, I want to make sure that we share the same vocabulary. When I say abortion in this chapter, I mean any loss or termination of pregnancy before viability, whether it's spontaneous or induced. Congenital, malformation, deformity, and anomaly all describe conditions that are present at birth. Chronic kidney disease, or CKD, is a long-term loss of kidney function, and GFR, or glomerular filtration rate, is the lab value we use to stage CKD. Gynecologists and low birth weight are also terms you'll see frequency in OB and in newborn records. So keep these in mind as we go forward. And there's a few additional terms like morbidity, which means illness or disease. Mortality means death. Obstetrics covers care through pregnancy, delivery, and the postpartum period, while perinatal focuses on the period around birth. Prenatal refers to the care before birth. You'll also see terms like prostatitis, purpurium, and urinary tract infection and urinary symptoms. I want you to connect each of these words to both the anatomy and the chapter numbers in ICD-10-CM. Now we're going to move into the kidneys and urinary system. In this section, I'll focus on conditions like CKD, hypertension with kidney disease, diabetes with renal complications, UTI, stones, etc. I want you to pay attention to whether it's a condition of acute or a chronic situation, what site is involved, and whether it's linked to another disease like diabetes or hypertension. These details impact our ability to select the correct codes. On the slide, I'm reminding you of the basic pathway for urine. Kidneys, ureter, bladder, urethra. The kidneys filter the blood and produce urine. The ureters carry urine to the bladder, where the bladder stores it, and the urethra carries it out of the body. From a coding perspective, I need you to listen carefully for the site. Is the problem in the kidneys? Is it in the ureter, the bladder, or the urethra? It's important to remember that this is site specific, so make sure that you get those sites for the appropriate, find the appropriate ICD-10 code for the sites, rather. They matter. And these are some of the diagnostic tests we're going to see with providers and who order the lab work done if they're suspecting kidney or urinary problems. Blood and urine tests tell us about the kidney function and infections. Imaging such as a KUB, which is basically an X-ray, ultrasound, CT, MRI, or IVP, intravenous parallelogram, um, will diagnose tumors, stones, cysts, obstructions. You're not going to code the test itself in ICD-10-CM. We're going to get to that later on with CPT coding in the spring, but you will use the results to determine the final diagnosis. So I want you to know why these tests appear in the chart. On this slide, I'm walking you through the stages of chronic kidney disease. CKD is long term. Usually it's a progressive disease and there is a loss of kidney function. The GFR value tells us which CKD stage to code from N18.1 for stage 1 all the way up to N18.6 for end stage renal disease. When you see GFR or language like stage 3 CKD or ESRD, I want you to immediately think about what N18 code applies. That staging impacts reimbursement and risk adjustment, so it's not an optional detail. So there is a relationship between hypertension and chronic kidney disease. When both hypertension and CKD are documented, ICD-10 guidelines tell us, so this is in the coding guidelines, they tell us to assume that causal relationship unless the provider clearly states another cause. That pushes us into the I-12 category for hypertensive chronic kidney disease. Then I still have to add the CKD stage from N18, but just keep in mind, whenever you see those two diagnoses together, think combination code plus CKD stage. Now I'm layering in diabetes, and we see a lot of patients that have hypertensive CKD and diabetes with renal manifestations. There are a lot of really sick patients out there. And when we add in the diabetes, that's another layer of complexity. When a patient has diabetes and kidney involvement, we want to use the diabetes codes with a fourth character of 2 to show renal manifestations. The first 3 characters tell us the type or the cause of the diabetes, and then the point 2 tells us the kidneys are affected. Then, just like with hypertension, I still have to add that N18 code for CKD. So, we want to make sure that we always add the stage of the CKD. So I want to really train you to look for phrases like diabetic retinopathy or diabetes with CKD. And if it is diabetes with CKD, just remember you have to add that stage to the CKD. On this slide, I'm talking about what happens when the kidneys can't do their job. Hemodialysis uses a machine to filter blood, and peritoneal dialysis uses the peritoneal membrane in the abdomen to filter. When you see dialysis in the chart, I want you to look for what type of dialysis, what kind of access the patient has, and whether the visit is about fitting or adjusting the catheter. This is where codes like Z49.01 and Z49.02 come into play. Some patients with end-stage renal disease are on a transplant list, and that would be Z76.82. Some are donors, Z52.4. Some have a functioning transplant, Z94.0. When there's a complication of the transplanted kidney, I want to code T86.11 to T86.19 to describe the complication, and then add codes for the specific condition like acute failure or rejection. I also have to decide if the disease is impacting the transplanted organ, the patient's remaining kidney, or both. So always read that documentation very, very clearly. As you've learned throughout this course, the documentation is the key to where and how you assign those codes. Acute renal failure is, as it sounds, it's an acute situation. It's often reversible. We see a decline in kidney function. I want you to look for words like acute, AKI, which is acute kidney injury, or acute tubular necrosis, or ATN. And you'll notice that the provider says acute, and if the provider says acute on chronic. If both an acute and chronic condition are documented, we may be coding both. So that little word acute makes a big, big difference. Many UTIs actually involve the bladder and are coded as cystitis, but we also see infections in the kidney and the urethra. I want you to be able to identify the site and also check the culture results for the organism. When an instruction note says use additional code to identify the infectious agent, that's your clue to go find that B95 to B97 code if the organism is named. Stones can sit in the kidney, they can travel through the ureter or end up in the bladder or urethra. Listen for where the stone is located, because that's what separates the N20 from N21 and N22. Patients with stones usually have severe flank pain and hematuria. They may undergo imaging or procedures like a lithotripsy. All of these will show up in the documentation that you're coding. When I see a C67 code, I want to know exactly where in the bladder the tumor is. Is it in the trigon, the dome, the lateral wall, the neck, or unspecified? That detail, again, comes from the documentation. And in the documentation, we want to look for the operative report. We want to look for the pathology report. If the provider doesn't specify a site, I may be stuck with coding unspecified part of bladder. But as we know, it's not ideal. So it's not ideal to code something that's not, that's unspecified. We want to be as specific as possible, and this could be a query opportunity. Now we're shifting into conditions of the male reproductive system. In this section, I'm going to walk you through common diagnosis like prostatitis, BPH, hydrocele, oligospermia, and erectile dysfunction. Now, as I talk through them, I want you to think about their symptoms and how they show up in code categories. Pay attention to whether laterality is documented for testicular conditions, because we know that matters in coding. So prostatitis is an inflammation of the prostate and often causes urinary symptoms. BPH is an enlargement of the prostate that obstructs urine flow. Hydrocele is hydro. We think of hydro, water, right? Cell is fluid around. So we have fluid around the testicle or spermatic code. Oligospermia is a low sperm count and may be part of an infertility workup. Erectile dysfunction, or ED, can have many causes. It can be vascular, neurologic, psychological, or even medication related. When I code these, I look for the cause, the site, and any link to an underlying condition like diabetes. So when we're coding sexually transmitted diseases, I want you to remember that accurate coding here supports not only the patient, but the public health system, because this information is sent to our public health for reporting. We'll look at chlamydia, gonorrhea, syphilis, HPV, etc. And as I talk about these, think about the type of organism, the site of infection, and whether the patient has an active disease, is chronic or late illness, or maybe this is just a screening. So you want to think about, have these in the back of your mind as you are looking at a chart, abstracting, coding. What's the story, right? So for bacterial vaginosis, that often ends up under vaginitis codes like N76.0. Chlamydia can affect the genitourinary tract, can also infect the eyes or other body sites. So I need to know exactly where the infection is showing up. When you see A55 or A70 or an A74 code, I want you to ask what organ or body system is involved. That's what's going to drive you to your final code choice. Here I'm focusing on genital herpes, gonorrhea, and HIV coding. Genital herpes is coded from A60.0 and depends on the site. Gonorrhea codes from A54 change based on where the infection is and whether there are complications like pelvic inflammatory disease or arthritis. For HIV, please remember the difference between B20, which is for HIV disease, and Z21 for asymptomatic HIV status. Once a patient has any HIV-related condition and is coded with B20, they stay a B20. They cannot go back to Z21. So again, it's very, very important that we look at that documentation and we don't give the patient a code that they don't have, because it's really difficult to get those documents amended after it's been coded. It can happen, they can get amended, but it is very difficult. So just like with HIV, opioid, alcohol abuse, any psychiatric conditions, really sensitive diagnosis, we want to make sure that we are coding appropriately. When the purpose of the visit is screening, I use Z11.51 for HPV screening. If the cytology results are abnormal, I may be using the R87.8 or R85.8 to report those abnormal findings. When HPV causes anogenital warts, I want to code the A63.0. So when I read the notes, I ask, is this screening? Is this an abnormal test results? Or is this a confirmed HPV-related diagnosis? Pelvic inflammatory disease, or PID, is an infection of the upper genital tract and often results from chlamydia or gonorrhea. With these diagnoses, I'm going to look for N73 or N74 codes and any link to a specific organism. For syphilis, I want to know if it's congenital, if it's early, late, or unspecified, because that changes the type of code I'm going to use. Again, stage and type and the documentation matter because they directly impact the code. We try to steer away from that unspecified code. We want to get specific if we can. We want to assign a specific code, and of course is based on that documentation by the provider. Trichomoniasis is a protozoal infection that can appear in the vagina or the urethra. When I see that in the chart, I'm going to look for A59 and for the language that tells me the site of infection. Sometimes patients are asymptomatic and the infection is found through screening. That's going to impact how I sequence screening versus a diagnosis code. Next, we have GYN care or gynecologic care, which is the female reproductive health outside of pregnancy. In this section, I'm going to talk about routine GYN exams, common disorders like endometriosis and fibroids, and visits to the fertility and procreative management. On this slide, I'm clarifying the roles of OB and GYN. Gynecologists focus on solely the female reproductive health outside of pregnancy, while obstetricians focus on pregnancy, delivery, and postpartum care. There are many providers that are combined OB/GYN, so I don't rely on the provider's specialty to kind of direct my coding focus. I focus on the reason for the visit. Why is the patient here? What are they having done? If the visit's about prenatal care, labor, or postpartum, I know that I'm going to fall into Chapter 15 O codes, right? If it's a routine exam or non-pregnancy conditions like fibroids, I'm in the GYN territory. So here I'm talking about routine gynecological exams. I use Z01.411 when there are abnormal findings and Z01.419 when there are none. If the provider documents abnormal findings, I must add codes for those conditions like dysplasia, vaginitis, or pelvic mass. If the note doesn't clearly say there are abnormal findings, don't assume it. Stick with the without abnormal findings code or query the provider. Endometriosis involves endometrial tissue growing outside the uterus, and that falls under N80 N80 rather. Uterine fibroids or leiomyomas fall into D25 category and are benign tumors of the uterine muscle. I may also see an R10.2 used for pelvic and perineal pain when no more specific diagnosis is documented. Of course, the rule of thumb here is if the cause is known, code the cause. If not, stay at the symptom level. And of note, endometriosis can impact your entire body. It says that with the uterine tissue growing outside of the uterus, it can impact the lungs, the peritoneum, it can impact your joints. It just can go everywhere. So important that you, when you code the endometriosis, you select the appropriate digit for that code. Here we talk about procreative management, and this is when the main reason for the visit is for fertility, genetic counseling, or planning for pregnancy. Codes in Z31 capture genetic counseling, carrier testing, and general procreative advice. When I see documentation about planning a pregnancy, assessing genetic risk, or investigating fertility, I'm going to think about Z31. These visits occur before the patient ever becomes pregnant, or usually occurs before the patient becomes pregnant because they're trying to become pregnant. So now we're going to pivot into routine obstetrics care. This is where there's normal pregnancy supervision and delivery when there are no complications. I want you to track trimester, weeks of gestation, or whether this is the first or subsequent pregnancy. Z34 codes capture supervision of normal pregnancy, and Z23.A codes capture the exact week of gestation. So just a very quick review, how pregnancy starts. When a sperm fertilizes an oocyte, we have a zygote that implants and grows. From a coding standpoint, I'm going to focus on Z32.01 for encounters where pregnancy testing is done and the results is positive. I also care about gestational age measured from the first day of the LMP or last menstrual period. The trimester definitions, first, second, and third, are based on weeks of gestation, and those drive our O and our Z34 codes. Now I'm going to focus on the Z34 category for just a moment, or excuse me, Z3A category for just a moment. For the individual weeks of gestation, Z3A gives me the exact week of gestation, like Z3A.20 for 20 weeks. I usually report a pregnancy complication code from the O chapter along with the Z3A code to add that extra level of detail. When I see something like 20 weeks and 3 days, I choose the code that best matches the completed week. So in every OB note, I'm scanning for the gestational age. On this slide, I'm decoding the shorthand you'll see in prenatal records. So this is really important. G stands for gravida, or total number of pregnancies. P stands for para, or number of births at or after 20 weeks. A stands for abortus, or number of pregnancies that ended before 20 weeks. When I see something like G3P1A1, I translate that as three pregnancies. one birth at or after 20 weeks and one lost before 20 weeks. And having that history coded, it helps explain why some pregnancies are considered high risk. So we have normal and high risk pregnancies, and there are different codes for that. Z34 codes are used when the pregnancy is considered normal and routine. There's no current complication, whereas 009 codes are used when there's a reason the pregnancy is at high risk, such as an advanced maternal age, prior complications, or multiple gestation. I also use Z33.1 when the patient happens to be pregnant, but that pregnancy is incidental to the visit. So, for example, if a patient presents to the emergency room, say they dislocated their knee and they had some blood workup done and it was determined that they are in fact pregnant. So that would be an incidental state. It's like, oh, by the way, this patient is here for this reason, but oh, by the way, the patient happens to be pregnant. So for labor and delivery, we need to remember for each delivery admission, I would need codes that describe the delivery and any complications, plus a Z37 outcome of delivery code. I pay attention to whether the delivery was vaginal or cesarean, whether labor was induced or spontaneous, and whether there were issues like fetal distress or prolonged labor. For multiple births, I pay close attention to the number of babies and their outcome because that directly impacts Z37 codes. Here I'm talking about when we can and cannot use Ch18. Ch18 is only for a single full-term uncomplicated delivery. If there's any significant complication at any point, pregnancy, labor, or delivery, Ch18 is no longer appropriate, and I go into the specific O codes for that complication. Examples include obstructive labor due to breech presentation, preterm labor with preterm delivery, or cord prolapse. So when I read the delivery note, I'm making a mental checklist, is this, what term is this? Is this preterm? Is this single? Is this multiple? Are there any complications associated with this delivery? So now, once the delivery occurs, we focus on the outcome of delivery. So that would be Z37. These codes describe whether the mother delivered a single or a multiple infant and whether they are live-born or stillborn. Z37 codes appear only on the mother's record. And I usually sequence them last on the claim related to delivery, because when I see that they're like twins or higher order multiples, I carefully read to see how many infants there actually were. Some moms have a lot of babies at once. This can happen too, related to fertility treatments. So it's important that you identify how many were live-born, if there were any stillborn, and pick the appropriate Z37 code. The last code that we'll see on the mom's chart is the Z37. We'll see a code from Z37 outcome of delivery. And once the baby is born, this creates a new chart. This automatically creates a baby chart. So you have a mom chart, you have a baby chart. And with the baby chart, the first thing that you'll see on that chart is a Z38 live-born infant code that tells us the place of birth and the type of delivery. So I always think of a mother and baby as separate coding stories that start and end in different places. So just remember that Z38 is not going to appear on the mom's chart. That's going to be the start of the baby chart. Now I'm going to move into pregnancies that are more complex. A pregnancy can be complicated by an existing condition like diabetes or by something that develops during pregnancy like gestational hypertension. In this section, I'll show you how the O codes capture these complications and how trimester and fetus identifiers come into play. So, for complications of pregnancy, we mean that a complication might threaten the continuation of a pregnancy, like ectopic pregnancy or threatened abortion. It might threaten the health of the pregnant patient, like hemorrhage or hyperemesis gravidium, or it might affect the care because of pre-existing disease or fetal problem. I'm always asking, does this condition change how the pregnancy is managed? And if it does, it's usually a complication that needs that O code. So these are some of the conditions that a patient can experience before while they're pregnant. Examples include chronic hypertension, pre-existing diabetes, and HIV. When these complicate pregnancies, I would head to the O10 to O11 categories for hypertension, O24 for diabetes, and O98.7 for HIV in pregnancy. I'm still going to code the underlying condition as well, so I'll have an O code plus an I, E, or B code. Sequencing is so important. The O code usually comes first because the pregnancy is the main context. So some things, conditions that arise during pregnancy, gestational hypertension is a new onset high blood pressure without significant proteinuria and falls into O13 category. Gestational diabetes is first diagnosed during pregnancy and falls into the O24.4 area. I may also see codes like O22.43 for hemorrhoids in the third trimester. But, I'm always going to ask if there are conditions that appear. I want to know, did this start during pregnancy or did the patient have this before? So that answer determines whether I use a gestational code versus a pre-existing code. So for multiple gestations, we're looking at code category O30, and this tells me how many fetuses there are and often note whether the placentas and amniotic sacs are shared or separate. Terms such as these are always tricky to pronounce. Monochorionic, dichorionic, and monoamniotic and diamniotic describe how the fetuses share or don't share these structures. Those details help me select the correct code and tell me how high risk the pregnancy is. O35 captures maternal care for known or suspected fetal abnormalities or damage such as heart defects or neural tube defects. O36 captures other fetal problems like poor growth or Rh isoimmunization. These codes explain why the mother is receiving extra monitoring or interventions. Once the baby is born and the condition is confirmed, then we're going to add a Q code onto the infant's chart. So if the pregnancy is a single gestation, we are going to report a 0. More than one fetus requires determining from the documentation which fetus is having that problem. So if you have numbers like 1, 2, or 3, that would identify the specific fetus in a multiple pregnancy. So if fetus number 2 had the cord around the neck, I would assign the code with the 7th character of 2 because that would tell me that the fetus number 2 or the fetus that was born second had a complication. So it's important to, again, capture that granularity of detail. After delivery, I would use codes like Z39.0, Z39.1, and Z39.2 for routine postpartum and lactation follow-up. These codes apply to the mom's care, not the infant. So we're not going to see these codes on the baby chart, right? We're just going to see it on the mom chart. If the mother has a postpartum complication like an infection or a hemorrhage, we're going to use that appropriate O code for that complication instead of a routine follow-up care. A sequela is a residual condition that remains after the initial complication is over. With obstetrics, I'm going to use O94 to show that a current condition is a late effect of a prior pregnancy complication. I code the current condition first, followed by O94. This is going to tell me the story that the current problem started because of something that happened in the past pregnancy, delivery, or the postpartum period. So with abortive outcomes, these can include ectopic pregnancies, molar pregnancies, and other abnormal products of conception, spontaneous abortions or miscarriages, complications of induced terminations, and failed attempted terminations all pertain to abortive outcomes. But the documentation that I'm looking at has to tell me which type occurred, whether there are complications like retained products of conception, hemorrhage, or infection. I always want to read those notes very, very carefully because, again, the wording changes the code. So in this section, we're going to talk about the first codes assigned to the baby's chart. So these are baby codes. These are on their baby chart only, not on the mom's charts. This is the very first code on the infant's chart, and that's Z38. Z38 tells me the place of birth, the type of delivery, for example, single live-born, delivered in hospital by cesarean. I'm never going to see that Z38 on the mom's chart. It only belongs on the infant's chart. After Z38, I want to add the codes for any neonatal conditions, any status codes, routine health exams as needed. Z05 are for newborns who are observed and evaluated for a suspected condition that is ultimately ruled out. The infant has no signs or symptoms. The team is just being cautious. If testing and observation show that the suspected condition is not present, I cannot use that appropriate Z05 code. On this slide, I'm defining what makes a newborn condition clinically significant. I code a condition if it requires treatment such as oxygen, antibiotics, or phototherapy. I also coded if it triggered additional diagnostic workups like special labs or imaging, or if it prolonged the hospital stay. These are my clues, and when the condition is being ruled out, we want to make sure that that is captured on the baby's chart. If a condition requires increased monitoring or nursing care, like continuous observation in a special care or NICU, I treat it as significant. We need to as coders. If the provider notes that the baby will need follow-up or ongoing care because of the issue, I also code it. My goal is to avoid overcoding a minor self-limited finding that had no impact on the care, while still capturing anything that changed how the care team managed the baby. So these codes are used when the newborn is affected by maternal conditions or complications of pregnancy and delivery. Examples include respiratory distress, intracranial hemorrhage, patent ductus arteriosus, or necrotizing enterocolitis that are related to the pregnancy or delivery. These codes appear on the infant's chart, not in the mother's, and so I would look for the language in the record that connects those two, connects the infant's condition to something that happened during the pregnancy. When newborns go in for a well baby check under 8 days, we're going to use Z00.110 health exam for newborn under 8 days. For 8 to 28 days, we would use the ICD-10 code Z00.111. For older children, we would do the .121. And if there's any abnormal finding, we would use the Z00.121, use that additional code to identify the normal findings. And if there are no abnormal findings, then we would utilize Z00.129. So let's talk about genetics for a sec. In a dominant disorder, one altered gene is enough to cause the condition. In a recessive disorder, the child needs two altered genes. An example of a dominant disorder includes familial hypercholesterolemia and familial retinoblastoma. Recessive disorders include cystic fibrosis and Gaucher's disease. I don't expect you to be a geneticist. I know I'm not, but it's important that we recognize that there are many Q codes that are tied to an inheritance pattern that we would need to capture on the baby's chart. A congenital anomaly is anything abnormal that is present at birth, whether it's genetic or environmental. A congenital malformation is a structural problem that developed during gestation, like a heart defect or limb abnormality. Some conditions are both genetic and congenital. Others are congenital but not inherited. Testing is done for genetic disorders, and we hear about things like amniocentesis and chorionic villus sampling, which are used during pregnancy to detect chromosomal or genetic disorders. I code the reason for the testing. This is often a high-risk pregnancy or suspected abnormality. That's O codes and Z codes, and the procedure itself with the CPT HCPCS when we do capture that in the spring when we learn about CPT and HCPCS. Again, I always read the note to see if the testing was routine, if it was high risk, or follow up for a known issue. Down syndrome falls under category Q90, sex chromosome abnormalities under Q98, cystic fibrosis under E84, Tay-Sachs E75.02, sickle cell disorders under D57. These conditions often have lifelong consequences and multiple complications, so you'll see them repeatedly in a patient's record. When I code them, I try to select the most specific subtype available instead of a generic unspecified code. So again, when the detail is there, go for that detail with that code if that is applicable. Do not select unspecified if there is more specific information that would allow you to assign a greater level of detail in that code. Multifactorial abnormalities are conditions that arise from both genetic and environmental conditions. Deformity here refers to the size or shape difference from normal structure. Examples include cleft palate, cleft lip, and cleft lip and palate. When I code these, I look for whether the defect is unilateral or bilateral and how complete it is. These occur when the defective gene is on the X chromosome and often impacts males more severely. An example is hemophilia A, coded as D66. This is a hereditary factor deficiency. Another example is Fragile X syndrome, coded as Q99.2. Once again, my main objective as a coder is to pick the correct disease code, but also use Z codes to capture carrier status and family history if they're documented and if it's relevant. I'm giving you a few major examples of congenital malformations here. So we have spina bifida, congenital diaphragmatic hernia, and congenital malformations of cardiac heart defects. So these conditions often require long-term follow-up and intervention, so you're going to see them throughout the patient's life, not just in the newborn period. All right, so we have reached the end. to wrap it up, we had a lot to talk about. We had a lot to learn for this chapter. But I want to pull back the big ideas and put them all together. Accurate coding in this chapter depends on understanding of the anatomy, the physiology, where, if any, there's a disease process occurring, if there's congenital issues. There's so many things that we need to look at. Recognizing key clinical and genetic terms, and carefully reviewing providers' documentations for details like stage, trimester, gestational age, site, and laterality, all help contribute to correct code assignment. When we're looking at CKD, we want to look for staging. We want to look for combination codes for like hypertension and diabetes with kidney disease. Review OB sequencing rules and neonatal significance criteria. These are all core skills that we need when we are coding these types of charts. Congenital and genetic conditions often shape a patient's health across an entire lifetime. So capturing them correctly is essential. We don't want to give them something they don't have, but on the same token, we want to accurately capture what they do have and what has been documented by the provider. As you review this chapter, I really, really encourage you to practice translating real-world documentation into precise coding practices. Review your coding guidelines, your ICD-10-CM coding guidelines, as well as your chapter-specific coding guidelines. So if you have any questions, please feel free to reach out to me. Again, I'll have my office hours on Wednesday from 3 to 4. If you need to meet, let me know. We'll set up a time. So I hope you have a great week, and I'll see you for the next chapter's lecture. Until then, bye.